Shock is most commonly due to hypotension, which is a systolic blood pressure less than 90 millimeters of mercury, or a mean arterial pressure less than 65 millimeters of mercury. And that leads to inadequate tissue perfusion and injury to various organ systems, like the brain, heart, kidneys, and liver. If left untreated, shock can cause irreversible multi-organ failure and death. Shock can be thought of as the following equation. The mean arterial pressure is equal to the cardiac output times the systemic vascular resistance. The cardiac output is equal to the heart rate times the stroke volume, and the stroke volume is dependent on the preload and the contractility. So the causes of shock can either be due to a decline in the cardiac output or the systemic vascular resistance. When one parameter decreases, normally the other increases to try to compensate. A decrease in the cardiac output can be due to decreased preload, decreased contractility, or a heart rate that's too fast or too slow. Decreased preload can be due to extracellular fluid volume depletion, like from diarrhea, excessive diuresis, dehydration, or hemorrhage. These are all causes of hypovolemic shock. Preload can also decrease if there's something obstructing the entry of blood into or out of a cardiac chamber, and this is called obstructive shock. For example, tension pneumothorax and pericardial tamponade can compress the inferior vena cava, obstructing blood flow to the right ventricle, and decreasing the cardiac output. A massive pulmonary embolism can obstruct blood from circulating through the pulmonary vessels and getting to the left ventricle. Cardiogenic shock is when the decrease in cardiac output is secondary to a decrease in contractility, like with congestive heart failure, myocardial infarction, myocardial contusion, or due to dysrhythmias. Alright, on the other hand of the equation, we have things that decrease the systemic vascular resistance, or in other words, result in peripheral vasodilation. These include anaphylactic, septic, and neurogenic shock, as well as certain disease states like acute adrenal insufficiency. Alright, the approach to an individual with suspected shock starts with the ABCs: airway, breathing, and circulation. The goal here is to detect life-threatening emergencies and address them immediately. The airway is evaluated for patency, and the easiest way to do this is to ask the individual to speak to you. A clear, coherent voice usually means that they can protect their own airway. If the individual is not breathing, or is unconscious with a Glasgow Coma Scale, or GSC less than 8, then endotracheal intubation and mechanical ventilation is performed. Also, signs like lip and tongue swelling or inspiratory stridors suggest anaphylactic shock. As for breathing, ventilation and oxygenation are assessed. For example, hypoxemia, decreased air entry, hyperresonance on percussion, and tracheal deviation to the opposite side might be seen in a tension pneumothorax. In such a case, immediate needle decompression is performed by inserting a needle in the second intercostal space on the affected side, which alleviates the compression of the inferior vena cava. Alright, as for the circulation, IV access should be obtained by inserting 2 large-bore peripheral intravenous lines. If it's difficult to obtain intravenous access, like for someone with hypovolemic shock, then an intraosseous line should be inserted. Central venous access, like an internal jugular, subclavian, or femoral vein lines, should be obtained if blood products or prolonged infusions of vasopressors are to be given. However, resuscitation should not be delayed simply because central venous access is not available. A small bolus of IV crystalloid fluid might be given initially as a fluid challenge, which assesses the person's response to fluids. Parameters like the mean arterial blood pressure or the urine output might be used to assess responsiveness. For example, hypovolemic and septic shock usually respond well to fluids, whereas cardiogenic and obstructive shock do not. Alright, now the vital signs offer more clues. Fever or hypothermia can happen in septic shock, although they're not always present. Shock caused by decreased cardiac output usually leads to a narrow pulse pressure, like a pressure of 70/60, for example. On the other hand, shock caused by a decreased systemic vascular resistance usually manifests as a wide pulse pressure, like a pressure of 100/30. It's also important to know a person's baseline blood pressure. For example, a blood pressure of 110/80 is actually low for someone with uncontrolled hypertension who has a baseline of 180/120. A recently studied parameter is the shock index, which is the heart rate divided by the systolic blood pressure. A shock index greater than 0.8 usually indicates shock, and the higher the number, the worse the shock. But a normal shock index value does not exclude shock. Now, tachycardia and tachypnea are classic compensatory responses to shock. However, if someone is on a medication like a beta blocker, this might blunt the tachycardia. Also, neurogenic shock, a complete heart block, or an overdose on beta blockers or calcium channel blockers can all cause bradycardia. On physical exam, cold extremities usually signify shock caused by a decreased cardiac output, because the body attempts to redirect blood flow away from the skin to more vital organs like the brain and the heart. On the other hand, in shock caused by a decreased systemic vascular resistance, the extremities are usually warm due to peripheral vasodilation. Increased jugular venous distension suggests obstructive shock, whereas a flat jugular vein signifies hypovolemic shock. Other common findings include signs of decreased end organ perfusion, like oliguria, which is defined as a urine output less than 0.5 cc's per kilogram per hour. Other signs are an altered mental status, which indicates decreased brain perfusion, and a prolonged capillary refill time, which indicates decreased skin perfusion. Generalized hives and wheals, flushing, and angioedema suggest anaphylactic shock. Alright, now during the resuscitation, the rapid ultrasound for shock and hypotension, or the RUSH exam, can be very helpful. The sequence of the exam can be remembered with the mnemonic HI-MAP, where H is for heart, and here we're mainly looking for a pericardial tamponade, which is immediately treated by doing a pericardiocentesis. It's also possible to look at the way the heart is beating, which might be abnormal in someone with cardiogenic shock. In addition, a significantly enlarged right side of the heart might be due to right heart strain from a pulmonary embolism. Alright, I is for the inferior vena cava, which provides an idea about the volume status in the central venous pressure, or CVP, which reflects the amount of blood returning to the right heart. A dilated IVC means that the CVP is high, which points toward obstructive or cardiogenic shock. A flat and collapsed IVC tells us that the CVP is low, which points towards hypovolemic or distributive shock. M is for Morison's pouch, or the hepatorenal recess, which is where fluid or blood can collect in the setting of trauma. We also look for free fluid in the splenorenal recess and in the pelvis. Any signs of trauma might mean needing to go directly to surgery for exploration. The A is for the aorta, where we measure the aortic diameter, looking for any signs of an aortic aneurysm. It's crucial that we look at the entire aorta, beginning from the xiphoid process all the way down to the abdomen until you see the aorta bifurcate into the common iliacs, which is usually just under the umbilicus. Finally, there's P, which is a reminder to look for a pneumothorax. Alright, now lab work depends on your clinical suspicion. A CBC might reveal a high hematocrit in non-hemorrhagic hypovolemic shock due to hemoconcentration. Hemorrhagic shock might initially show a normal hematocrit because a person loses red blood cells and a proportional amount of plasma with it. But later, only after they're resuscitated with fluid, does the anemia appear. An elevated eosinophil count can occur in anaphylaxis or adrenal insufficiency. Leukocytosis might indicate septic shock, but it could just be a response to the stress of any type of shock. On the other hand, leukopenia or presence of immature neutrophils called band cells are more specific for sepsis. Thrombocytopenia, as well as coagulation studies like a prolonged prothrombin time, might clue towards coagulopathy as a cause of hemorrhagic shock. Lactate levels might reflect poor tissue perfusion, and elevated levels are correlated with increased mortality, especially in septic shock. Lactate levels are quite helpful in identifying shock, especially in individuals who have a normal blood pressure, and serial lactate levels can be used to assess response to therapy. While high lactate levels are abnormal, low lactate levels should not reassure you if there are other concerning signs of shock. In shock, there's also usually a high anion gap metabolic acidosis. Elevated blood urea nitrogen and creatinine levels can indicate that there's a pre-renal acute kidney injury secondary to hypovolemia. An ECG might show ischemic changes. Electrical alternans, which is alternating amplitudes of a QRS complex, a sign of pericardial effusion, or even signs of right ventricular strain to pulmonary embolism, like an S1Q3T3 pattern. If a myocardial infarction is suspected, then troponin levels might be obtained, and if congestive heart failure is suspected, then a chest X-ray and brain natriuretic peptide, or BNP levels, can be checked. If septic shock is suspected, then blood cultures, urinalysis, and a chest X-ray should be checked to look for a source. When suspecting anaphylactic shock, serum tryptase levels, a marker released from mast cells, should be obtained. Management depends on the cause of shock, so let's start with hypovolemic shock, which might be non-hemorrhagic or hemorrhagic. Non-hemorrhagic hypovolemic shock might result from gastrointestinal losses like vomiting or diarrhea, renal losses like excessive diuresis in diabetic ketoacidosis or diabetes insipidus, excessive sweating like in hyperthermia or hyperthyroidism, or third spacing. Third spacing includes anything that causes intravascular fluid to shift into the interstitial or intracellular space, like burns, intestinal obstruction, or acute pancreatitis. In addition to the manifestations of shock, other clues include signs of dehydration, like dry mucous membranes and decreased skin turgor. Treatment includes replacing the lost fluids, usually with IV crystalloids like normal saline, correcting any electrolyte abnormalities, and addressing the underlying cause. Hemorrhagic shock usually results from a trauma, and can be obvious, like bleeding from the scalp or a long bone fracture, or it could be occult, like intraperitoneal or retroperitoneal bleeding. It can also be non-traumatic, like with gastrointestinal or genitourinary bleeding, or a ruptured ectopic pregnancy. Importantly, a ruptured abdominal aortic aneurysm should be suspected in an elderly individual presenting with back or flank pain, syncope, and hypotension. Management includes applying direct pressure to the bleeding if possible, and providing blood products. Packed red blood cells, fresh frozen plasma, and platelets are usually given in a 1:1:1 ratio. Type in cross-matched blood is ideal, but takes time to prepare. Therefore, type O negative blood can be given if needed immediately. Counterintuitively, it's best to avoid giving too much IV crystalloid fluid if possible, because it might dilute clotting factors in the blood, potentially worsening the hemorrhage. If they're bleeding, give them blood. Finally, if surgery is necessary, then getting them to the operating room is the priority. Alright, when it comes to obstructive shock, attention pneumothorax and pericardial tamponade are managed by a needle decompression or a pericardiocentesis. Another cause is a pulmonary embolism, and the diagnosis is made with a CT angiogram of the chest. Anticoagulation is provided with low molecular weight or unfractionated heparin followed by warfarin. When a PE is massive enough to result in shock, thrombolytics like TPA are indicated. In cardiogenic shock, the weak heart needs some temporary support, and the two main forms are inotropic support and mechanical support. Inotropic medications like dobutamine, a beta-1 receptor agonist, or milrinone, a phosphodiesterase inhibitor, act to improve cardiac contractility. There are also mechanical support devices that can be used. For example, an intra-aortic balloon pump, or IABP, is a balloon device inserted percutaneously and advances up to the aorta. The device synchronizes with the cardiac cycle. It inflates during early diastole, which increases diastolic coronary blood flow, and then it deflates during systole, reducing the afterload and dramatically improving cardiac output. But because IABPs sit within the vasculature, they increase the risk of thrombosis, and therefore individuals need to be anticoagulated with medications like heparin. Alright, now if a myocardial infarction is the cause of cardiogenic shock, then the individual is taken to the catheterization lab to identify and revascularize the occluded vessel using coronary angiography and percutaneous coronary intervention, or PCI. In a myocardial infarction that causes cardiogenic shock, thrombolytics typically don't work, because there isn't enough circulation to actually get adequate amounts of the thrombolytic to the coronary vessels. Finally, if the cause is a tachyarrhythmia, then the usual treatment is cardioversion or defibrillation. And if it's a bradyarrhythmia, then atropine is usually given and cardiac pacing is done. Alright, on to distributive shock. When sepsis is suspected, management starts by obtaining blood cultures and giving empiric antibiotics and IV fluids, ideally within the first hour of presentation. A preferred regimen includes vancomycin plus a second antibiotic like a third-generation cephalosporin or piperacillin tazobactam or a carbapenem. IV crystalloid fluid should be given within the first 3 hours at a rate of 30 milliliters per kilogram. Now, if despite adequate fluid resuscitation, vasopressors are required to maintain the mean arterial pressure above 65 millimeters of mercury, and the lactate level is greater than 2 millimoles per liter, then it's considered septic shock. Norepinephrine is the preferred first-line vasopressor, and if it fails to maintain the blood pressure alone, then vasopressin is added. Other options include epinephrine and phenylephrine. If the individual fails to respond to 2 or more vasopressors, then glucocorticoids like IV hydrocortisone and inotropic agents should be considered. Anaphylaxis is an acute, life-threatening syndrome caused by IgE-mediated release of vasoactive mediators, like histamine and bradykinin from mast cells and basophils in response to various allergens. Some triggers like opioid medications can induce release of mediators in a non-IgE dependent fashion, and this would be called an anaphylactoid reaction. There are 3 potential presentations that should raise your concerns for anaphylaxis. First is an acute onset of skin or mucosal tissue symptoms, like hives, pruritus, or angioedema, along with at least one of either respiratory symptoms like stridor or wheezing, or hypotension. The second presentation is presence of 2 of the following after exposure to a likely allergen: skin and mucosal symptoms, respiratory symptoms, hypotension, and gastrointestinal symptoms like crampy abdominal pain, vomiting, or diarrhea. The third presentation is simply hypotension after exposure to a known allergen, like an insect bite. As soon as anaphylaxis is suspected, the first and most important thing to do is inject 0.3 to 0.5 milligrams of 1 in 1,000 epinephrine intramuscularly, which means 1 gram of epinephrine diluted in 1,000 milliliters, or in other words, 0.01%. In a standard 1 in 1,000 vial of epinephrine, there's 1 milligram of epinephrine per 1 milliliter. Sometimes this dose needs to be repeated. This is crucial to differentiate from the 1 in 10,000 epinephrine used in cardiac arrest. The IV route is an alternative, but there's a risk of dosing error, which can cause ventricular arrhythmias, and therefore the intramuscular route is preferred. Epinephrine increases cardiac output, relaxes the smooth muscle of the airway, and causes vasoconstriction, all of which leads to increased blood pressure and reduced movement of intravascular fluid into the interstitial space, which reduces mucosal edema. Now, if an individual is on a beta blocker, that can blunt the effect of epinephrine. To get around that, glucagon can be used. Glucagon does not rely on beta receptors and can potentiate the effect of epinephrine. In addition, because massive amounts of fluid shift to the interstitial compartment, it's also important to give IV crystalloid fluids. If there are signs of upper airway compromise, like stridor or lip or tongue swelling, then intubation might be needed. But you should always give epinephrine first, because it might actually reduce the need for intubation. If intubation is difficult due to significant upper airway swelling, then a surgical cricothyroidotomy can be performed. There are also some additional medications that help with symptom relief. Oral or IV antihistamines like diphenylhydramine or ranitidine might be given. Sometimes a less severe episode of anaphylaxis can recur within 72 hours after the initial episode, and this is called a biphasic reaction. Glucocorticoids like methylprednisolone have a delayed onset of action, so they're thought to help reduce the risk of a biphasic reaction. Beta-2 agonists like albuterol do not help relieve the upper airway angioedema, but they do help with lower airway bronchospasm. Interestingly, people with pre-existing coronary artery disease have lots of mast cells in the coronary circulation. When anaphylaxis happens, vasoactive mediators can trigger plaque rupture, leading to a myocardial infarction. And this unique phenomenon is called Kunis syndrome. In addition to managing anaphylaxis, percutaneous coronary intervention should also be performed. Finally, prior to discharge, it's crucial to educate individuals and their family members on how to use epinephrine autoinjectors like the EpiPen. Next up is neurogenic shock. Now, sympathetic innervation of the heart originates from T1 to T5 spinal cord segments. Injury to these segments might potentially result in loss of the sympathetic innervation, which results in unopposed parasympathetic stimulation, causing hypotension due to peripheral vasodilation and bradycardia. Massive peripheral vasodilation can also cause priapism. Treatment includes IV crystalloid fluids and vasopressors like norepinephrine, phenylephrine, or dopamine. A common mix-up is spinal shock, which is technically a misnomer, but it does not affect the circulatory system. Instead, spinal shock is a temporary state of flaccid paralysis and loss of sensation below the level of the spinal cord injury. The final type of distributive shock is acute adrenal insufficiency, or adrenal crisis, which is a rapid decrease in the glucocorticoid cortisol and the mineral corticoid aldosterone. This is classically caused by sudden cessation of chronic exogenous glucocorticoids, like someone with asthma or COPD, or failure to increase the dose during times of stress, like infection or surgery. Individuals develop hypotension refractory to fluids and vasopressors, altered mental status, and even abdominal pain. Lab work shows hyponatremia, hyperkalemia, hypoglycemia, and non-anion gap metabolic acidosis. A CBC might show eosinophilia on the differential. Treatment includes IV hydrocortisone to replace the cortisol, and IV fludrocortisone to replace the aldosterone. Fludrocortisone is used because it has the greatest mineral corticoid effect of all of the exogenous steroids. Alright, finally there's toxic shock syndrome, which is caused by bacterial exotoxins that act as superantigens and can generate a hyperactive immune response. The most common culprits are Staphylococcus aureus and group A beta hemolytic streptococci. Classically, individuals have a history of tampon use, nasal packing or gauze-packed wounds. Symptoms include fever, vomiting, diarrhea, hypotension, and a diffuse erythematous rash resembling a sunburn. There's often multi-organ failure, leading to an elevated creatinine and aminotransferase levels. Treatment includes removing the potential source, giving IV crystalloid fluids, and broad-spectrum antibiotics like a carbapenem. Alright, as a quick recap, shock commonly causes hypotension, which is the systolic blood pressure less than 90, or a mean arterial pressure less than 65, as well as end organ damage, which can be irreversible if left untreated. Shock results from decreased cardiac output or decreased systemic vascular resistance. Causes of decreased cardiac output include hypovolemic, cardiogenic, and obstructive shock. And causes of decreased systemic vascular resistance are anaphylactic, septic, and neurogenic shock, all under the umbrella of distributive shock. Evaluation of shock starts with the ABCs: airway, breathing, and circulation. The airway is assessed for patency, and intubation is done if the individual is not breathing, unconscious with a GSE less than 8, or if they're in anaphylactic shock. Breathing includes assessing ventilation and oxygenation. If there are signs of tension pneumothorax like decreased air entry, hyperresonance on percussion, and increased jugular venous distension, then needle decompression is performed immediately. After that, for circulation, 2 large-bore intravenous lines are inserted, and a fluid challenge is initiated. Cold extremities usually signify a decreased cardiac output, whereas warm extremities point toward a decreased systemic vascular resistance. Rapid ultrasound for shock and hypotension is a helpful tool to look for multiple potential pathologies, like pericardial tamponade. Initial investigations include a CBC, blood urea nitrogen, and creatinine levels, lactate, an arterial blood gas analysis, troponin and BMP levels, and an ECG. If septic shock is suspected, blood cultures, a urinalysis, and a chest X-ray are done to look for a source of infection. Hypovolemic shock is treated with fluids and blood transfusions if it's hemorrhagic. Obstructive shock is treated by treating the underlying cause, like a pericardiocentesis for a pericardial tamponade, or anticoagulation and thrombolysis for a pulmonary embolism. Cardiogenic shock is treated with inotropes, like dobutamine, mechanical devices like an intra-aortic balloon pump, and percutaneous coronary catheterization if a myocardial infarction is the cause. Septic shock is treated with empiric broad-spectrum antibiotics, vasopressors like norepinephrine and vasopressin, and if they fail, then glucocorticoids and inotropes might be added. Anaphylactic shock is treated with intramuscular epinephrine, airway management, and medications like antihistamines and glucocorticoids. Neurogenic shock is treated similarly to septic shock, without the antibiotics. Adrenal insufficiency is treated with IV hydrocortisone and fludrocortisone. Finally, toxic shock syndrome is treated by removing the inciting foreign body along with empiric antibiotics.